Is the topic interrelationship between periodontics and endodontics. You all know what are endodontic problems and what are periodontal problems, but there are certain cases when the patient exhibit both the problems, the endodontic as well as the periodontal problems. In that case, how to go for the treatment, how to diagnose, this we are going to deal in this chapter. Now what happens, you know that your periodontium and pulp, they are interrelated. Okay, how they are interrelated? By means of your apical foramen, lateral canals. Okay, this creates a pathway for the exchange of noxious agents between the two tissue compartments. That means whatever is the pulp, the the it can reach to the periodontium. Okay, and similarly any noxious agents in the periodontium can reach to the pulp because they are connected through apical foramen and lateral canals. So, under certain clinical conditions, diseases in one of the tissue compartments may result in pathological condition in the other. Now, influence of pathological conditions in the pulp on the periodontium. Impact of disease conditions in the vital pulp. So, we are doing here the vital pulp when there is no, the pulp is vital. Okay, so other condition is when the pulp is non-vital. So first we are going to deal with the vital pulp. Okay, in this condition the disease process in the dental pulp frequently involve inflammatory changes. Inflammatory changes, you know what can be the inflammatory changes in the vital pulp, your reversible pulpitis. Okay, like caries, restorative procedures and traumatic injuries are the other causes. Now, any loss of hard tissue integrity exposing dentine or the pulp directly may allow bacteria and bacterial products elements present in the oral environment to affect the normal condition of the pulp. Now, integrity in the hard tissue means your dentine, pulp, if they are involved, they are exposed, there is the bacterial products, they can then reach the pulp. You all know what this is all what happens in your caries. Okay, now the resulting inflammatory lesion will be confined and directed towards a source of irritation for all as long as the inflammatory defense does not collapse and convert into the destructive breakdown of the pulpal tissue. So what happens, for some time you all know that our body tries to adapt. Okay, we have done this adaptive remodeling in trauma from occlusion also. Okay, how the periodontium adapts. Similarly, the pulp also, it tries to adapt. Okay, there will be some inflammation in the pulp, there will be irritation from the oral environment, so pulp will be inflamed, but it will not break down. Okay, so after some time the destructive breakdown of the pulp tissue will start. So occasionally the disruption of the apical lamina dura or widening of the periodontal ligament space may be seen in the periodontium. So after some time you can say then the pulp tissue is involved. Okay, and there is destruction of the pulp tissue. Okay, which can go from the apical foramen, from the lateral canals into the periodontium. So what is the early sign that you can see? You can see there is the widening of the periodontal ligament. Okay, and in radiographically there is disruption of the apical lamina dura. Okay, and the space is increased in the periodontium. Okay, widening of periodontal ligament means there is increase in the width of the lamina dura. In such instances, typical clinical signs of pulpitis, example spontaneous pain, thermal sensitivity or tenderness to percussion may or may not be present. So when the pulp is irritated, okay, it is gone to the apical foramen, right? To the periodontium, there is widening of the PDL, I have told you. But typical signs, if you are looking for the typical signs, you know, that spontaneous pain, you know that it is pulpitis. Okay, and then you ask the patient ठंडा गरम तो नहीं लग रहा है, you know, that is like hot and cold sensitivity, है ना. So that and then TOP, you keep checking with TOP. Okay, that may or it may not be present, it may be the starting stage. Okay, so the typical clinical signs may not be present. So it is important to realize that as long as the pulp maintains vitality, although inflamed or scarred, it is unlikely to produce irritants that are sufficient to cause pronounced marginal breakdown of the periodontium. So what we are I want to tell you here is, whatever, if first you should check for your pulp vitality. Okay, if your pulp is vital, then it is not going to make any pronounced effect on your periodontium. Okay, so you should not consider it, then it is an endodontic problem. Okay, it is not going to lead to periodontal problem. Consequently, no benefit will be gained from pulpectomy, okay, as an adjunct to treatment of teeth for periodontal disease. अब you have a tooth, ठीक है, there is a pulpal problem, reversible pulpitis, but the tooth is vital. Along with that, you have a periodontal pocket. So in that case, don't just like endo-perio, like go for pulpectomy. Okay, in that case, you should understand your pulp is vital. You should go for the treatment of the periodontal disease. There is no need of your pulpectomy. So, what is the impact of pulpal necrosis? Pulpal necrosis means your tooth is non-vital. Okay. Now, contrary to the disease conditions in the vital pulp, pulp necrosis is frequently associated with inflammatory involvement of the periodontal tissue. Now, invariably, it is associated. Okay. So that means if your uh, pulp necrosis has occurred, it is non-vital, then it can lead to your periodontal disease frequently. Okay, now lesions are most often located at the apex of the tooth. जो आपका periodontal involvement होगी, that will be at the apex of the tooth through the apical foramen. Okay, but it can also occur through the lateral canals. Okay, but frequently through the apical foramen, but may also occur at any site where lateral canals exit into the periodontium. Now, manifestations of endodontic lesions in the marginal periodontium from the lateral canals. Okay, how it appears in the periodontium if it is from the lateral canals. Now, inflammatory lesions may develop from a root canal infection at the lateral aspect of the root and in furcation regions of multi-rooted teeth. The lesions may be induced and maintained by bacterial products which reach the periodontium through the lateral canals. So lesion appears to be rare and do not seem to emerge at a rate that corresponds to the frequency with which lateral canals occur in the teeth. So there are many lateral canals in the teeth. Okay? So don't expect, okay, through each of the lateral canals, you're getting the lesions. Okay? Not at that rate, but yes, they can appear through the lateral canals. Okay. Now, manifestations of acute endodontic lesions in the marginal periodontium. Endodontic lesions either do not have overt clinical signs or may present with various acute infection of the root canal infection. So the asymptomatic lesions usually assume a limited extension around the apex, while rapid and extensive destruction may extend marginally along the attachment apparatus or also may follow the acute exacerbations. ठीक है, तो acute exacerbations means your abscesses, they can also be formed. Okay, now exudation and pus formation in the process may drain off in different directions, pathways along the periodontal ligament space, following penetration of alveolar bone at the apical region with drainage in or near the gingival sulcus pocket warrant particular attention from differential diagnostic point of view. In addition to deep pocket probing depths, the accompanying bone lesion may mimic that of periodontitis. So, from the pulpal origin, when it is reaching the periodontium, it may look like as if deep pocket is formed, and that is the periodontitis, but it is from the pulp, that is endo-perio. Then impact of endodontic treatment measures on the periodontium. When breakdown of periodontal tissues associated with the root filled tooth, endodontic etiology should be taken into account, particularly if the root filling is of poor quality. So if the tooth has already been endodontically treated, okay, and still the problem arises, so in that case you should understand that, try to see if the endo treatment or the root canal filling is done of good quality. Okay, then unfilled spaces in the endodontically treated root canals can sustain the bacterial growth. Okay, that is if you know how to see the obturation, okay, how it is done. So if there is unfilled spaces, so that can also lead to bacterial growth, okay. So they can also reach the periodontium along the very same pathway as an untreated tooth with infected pulp, okay. Just don't see, okay, as it is done, then there is no peri problems. You have to see how it is done radiographically. You can appreciate that, okay. Then, endodontic retreatment may be considered as an adjunct to periodontal therapy when a root canal filling is of poor quality or displays signs of periapical inflammation because of the potential that bacterial elements may become disseminated to the periodontium along the dentinal tubules exposed by periodontal instrumentation. Okay. Now, periodontal inflammatory lesions may also result from mechanical as well as chemical irritation initiated by root canal treatment. Okay, sometimes you irrigate, okay, your root canal, the irritant chemical, it can go from the apical foramen into the periodontium. That can also lead to periodontal inflammatory lesions. Okay, however, medicaments for irrigation and disinfection as well as the materials that are used to fill in modern endodontics are comparatively well tolerated by connective tissue of the periodontium, even if during treatment they are forced in the periodontal ligament. So this condition is comparatively, very few cases are like that. Maybe patient is hypersensitive, sometimes patient is very allergic, then it can occur. But otherwise, in the modern endodontics, the medicaments that we are using for the irrigation, okay, and whatever filling material we are using, they are compatible with the periodontal tissues, right? So another thing that come across is endodontics is root perforations, okay, very common. Again, this can also happen, your canals, you know that your canals are curved, okay. So during endodontic treatment, instrumentations can accidentally result in perforation of the root, and a slight perforation, you are into the PDL, periodontal ligament. So perforations can be made through the lateral wall of the root or through the pulpal floor in a multi-rooted tooth, okay. You know, furcation area, multi-rooted tooth, that you can also go into the furcation. If you go into the furcation, again you are in the periodontal ligament. So these are certain things which can be iatrogenically done by the dentist, okay, during performing the root canal treatment. So here you can see how root perforation, okay, the furcation. So the clinical course from then depends largely on the extent the wound site becomes infected. Now, if it is a very slight perforation, okay, so after some time, you know, it is going to heal, body is going to heal itself, but depends on the extent the wound is infected. Now, if the perforation is more apical along the root, a wound site infection process may first lead to acute pain condition, including like abscess formation, okay, and drainage of pus, followed by further loss of fibrous attachment and periodontal pocket. So if it is going to be slight, okay, it is going to heal on its own, no worries. But if it is along, more apical along the root, okay, then you are going to a patient is going to have pain. There can be abscess formation, drainage of pus, and further loss of fibrous attachment, leading to periodontal pocket formation. So if an iatrogenic root perforation occurs during instrumentation of root canals, filling of the artificial canal to the periodontium should be carried out without delay to prevent granulation tissue formation and wound site infection. So that artificial canals means canal that you have prepared. You prepare the canals, you know, endodontic treatment. So when you have, if you have done the root perforation, you should try to complete the procedure, okay. Just fill up it, obturation kar lo, fill kar lo artificial canal ko, what you have prepared, okay, so that once it is filled, then there is no movement of irritants between the two tissues, the endodontal tissues and your periodontal tissues. So no granulation tissue formation, and it can heal, okay. So another thing that we come across in endodontic procedures or in patients with endodontic problems is your vertical root fractures. Vertical root fractures you heard of, okay. So the clinical symptoms are very typical of tooth associated with endodontic infections, and plaque induced periodontitis may also appear in teeth with vertical root fractures. So the symptoms the patient exhibit in vertical root fractures are similar, quite similar to the endodontic symptoms or the plaque induced your periodontitis. So, a vertical root fracture is defined as a fracture of a root that is longitudinally oriented at more or less oblique angle relative to the long axis of the tooth. ठीक है? A vertical root fracture can extend the entire length of a root and then involve the gingival sulcus or pocket area, or it may be incomplete and confined to the coronal or the apical end. So, depends how what it can go along the length of the root, complete vertical root fracture, or partial coronally. It can be, a lesser impact, that the fracture line does not reach to the apex and it is somewhere confined to the coronal part. So what is the clinical expression in vertical root fractures? You should know that the clinical signs and symptoms associated with vertical root fractures vary hugely. Okay, there may be pronounced pain symptoms and abscess formation because of active bacterial growth in the fracture space. In other instances, clinical symptoms may be limited to tenderness on mastication, mild pain, and dull discomfort. So it varies. Some patients may feel tenderness on mastication, okay, a light tenderness, they will feel dull discomfort, okay, mild pain, they will think, and then you will think, okay, maybe it is periodontal problem. If the patient says, okay, I have abscess formation, a very pronounced pain, then you will think it is of endodontic problem, but it can be a simple vertical root fracture, okay, neither endodontic nor periodontal problem. So you should be able to understand this. What is the vertical root fracture? So a strong indication of a vertical root fracture is sinus tracts occurring at both buccal and lingual palatal sites. So if there are sinus tract, the abscess is there, then chronic condition, the sinus is formed. So if the sinus is on both the buccal and the lingual or palatal side, that means it is on both the sides, vertical root fracture. In other instances, what you can observe, a narrow local deepening of a periodontal pocket in an area not typical for periodontal disease may be the only clinical finding. That means the patient is otherwise having a quite normal periodontium, but localized at certain one point only, one tooth only, he is having a deepening at the periodontal pocket, okay, which is not so typical of a periodontal disease, because what is a periodontal pocket, all of you, and what are the clinical symptoms of a pocket. So it is not that typical periodontal disease, but there is deepening. So in that case also you can think of a vertical root fracture. See, sinus, and there is normal periodontium. You can see there is your probe is going very deep in one of the tooth. So you can think of a vertical root fracture. So the diagnosis of a vertical root fracture is often difficult to ascertain because the fracture is usually not readily detectable by clinical inspection unless there is a clear separation of the root fragments. Now, if you are thinking of vertical root fracture, but you have to ascertain it, okay, yes, this is my diagnosis. Okay, so if you can inspect it, okay, your root fragments are separable, then you can know that this is a vertical root fracture. But sometimes they are not so separated, okay, you can't ascertain it by inspection. Then give a radiographic appearance of the fracture in the absence of separation. You can see it radiographically. The central x-ray beam has to be parallel to the fracture plane. Okay, this is the way you take your radiograph. Now, treatment considerations. Now, radiographically, okay, or by inspection, you have confirmed that this is a vertical root fracture. So what all treatment you can go for? So vertical root fractures that involves the gingival sulcus pocket area usually have a hopeless prognosis due to continuous bacterial invasion of the fracture space from the oral environment. Okay, while there are reports of successful management of fractured teeth by reattaching the fragments with bonding resin or laser fusing after extraction followed by reimplantation, fractured teeth are normally candidates for extraction because it has a poor prognosis most of the times. Okay, teeth are going to go for extraction, but some cases you can try to reattach the fragments. Okay, now the clinical presentations. Root resorptions do not cause painful symptoms. Okay, take it. Now another thing is your root resorption. Sometimes, okay, root resorptions can occur. Okay, in that case they are not going to cause any painful symptoms. unless a resorptive process is located coronally and is undermining the enamel, giving it a pinkish appearance. The only way to detect and diagnose dental resorption is by means of radiography, because clinically root resorption you don't know, okay, that is occurring, but radiographically you can diagnose it. So root resorption is of following types: surface resorption, replacement resorption associated with ankylosis, inflammatory resorption associated with persistent inflammation in the periodontium adjacent to the resorption site. Subforms are like your peripheral inflammatory root resorption, okay, external inflammatory root resorption, okay. You have done some of it in oral pathology, or somewhere you have studied about root resorption also, so you know how it occurs. Now, surface resorption. This type of resorption is common, self-limiting and reversible. In a histological study of human teeth from individuals varying in age from 16 to 58 years, only 10% of the teeth showed absence of active resorptions or signs of healed resorptions. Resorptions were noted twice as often in older than in young subjects. Another study demonstrated up to 88% of teeth with active, or in most instances, healed. Now, the mechanism behind surface resorptions are only partly understood. These resorptions are normally initiated in conjunction with a localized injury to the cementoblast cell layer, for example, by external trauma or by trauma from occlusion. Okay, so how the resorption can occur? By injury, okay, external trauma. Then, as the class cells are attracted to the denuded root surface, hard tissue is resorbed for as long as the activating factors are released at the site of injury. The resorptive process then stops within a few days following the disappearance of class cells, along with the defect becoming populated with hard tissue repairing cells, leading to cementum repair. So the resorption, it can stop on its own. The cementoblast appear, then the cementum repair starts. So the regulatory factors that govern this process is virtually unknown. What is how it is regulated? Okay, how resorption is there with the osteoclast, and then after some time the osteoblasts appear, the cementum is repaired. तो इसको जो factor govern कर रहा है, what is controlling the resorption is unknown. So the signs of active or healed surface resorptions are common in large majority of teeth of the adult dentition. It is conceivable that the minor trauma caused by unintentional biting on hard objects, bruxism, high filling cause localized damage to the periodontal ligament and trigger the initiation of this type of resorption. Then is your replacement resorption. This type of resorptive process involves replacement of the dental hard tissue by bones, hence the name, When a surface resorption stops, cells from the periodontal ligament will proliferate and populate the resorbed area. If the surface resorption defect is large, it will take some time before periodontal ligament cells have covered the entire surface. The external inflammatory resorption. The term external inflammatory resorption describes the presence of an inflammatory lesion in the periodontal tissues adjacent to a resorptive process. There are two main forms: peripheral inflammatory root resorption and external inflammatory root resorption. Both forms are triggered by destruction of cementoblasts and the cementoid. So this is your influence of endodontic conditions on the periodontal tissue. Now we are going to deal with influence of periodontal disease on the conditions of the pulp. Now the formation of bacterial plaque on detached root surfaces following periodontal disease has the potential to induce pathological changes in the pulp along the very same pathway as endodontic infection can affect the periodontium in the opposite direction. So this I have told you in the beginning, that both the tissues are interrelated with your apical foramens and the lateral canals. Thus, bacterial products and substances released by the inflammatory process in the periodontium may gain access to the pulp, okay, via, as you know, lateral canals, apical foramens, as well as the dentinal tubules. A clear-cut relationship between progressive periodontal disease and pulpal involvement, however, does not invariably exist. In fact, while inflammatory alterations as well as localized necrosis of the pulp tissue have been observed adjacent to lateral canals in the teeth exposed by periodontal disease, A number of clinical studies have failed to confirm a direct correlation between periodontal disease and the pulp tissue changes. It seems that periodontal disease rarely jeopardizes the vital condition of the pulp. Breakdown of the pulp does not occur until the periodontal disease process has reached a terminal state, that is, when bacterial plaque involves the main apical foramen. As long as the blood supply to the apical foramen remains intact, the pulp is capable of withstanding the injurious elements released by the lesion in the periodontium. So, periodontal tissues are rarely affecting the pulp. They can affect, but it is not very common because the vitality of the blood is maintained through the blood vessels that are coming in the through the apical foramen. So the if the periodontal disease, okay, it extends, attachment loss is so much that it reaches the apex of the tooth, only in that condition it is going to affect the pulp. Otherwise the pulp maintains its vitality. So influence of periodontal treatment measures on the pulp: scaling and root planing, root dentin, hypersensitivity. Differential diagnostic consideration: recognition of pulp vitality is essential for differential diagnosis. So I have told you earlier also, first you have to check the vitality of the pulp. And for the selection of primary measures for the treatment of inflammatory lesions in the marginal and apical periodontium. Deep restorations, dental trauma, endodontic treatment, previous pulp capping, etc. are the factors to consider when assessing the need for endodontic treatment. So location, form and extension of radiolucences, as well as your clinical symptoms like pain, tenderness, abscess formation, increased probing depth, etc. may not allow distinguish a periodontal lesion from an endodontic lesion. So treatment strategies for a combined endodontic and periodontal lesions. Treatment of combined endodontic and periodontic lesions does not differ from the treatment given when the two disorders occur separately. So here it is in this table, it is shown if there is an endodontic problem, the pulp is non-vital, go for the endodontic treatment. Periodontal problem, the cause is periodontal, pulp is vital, go for the periodontal treatment. Okay, endodontic and periodontal, both the problems are there, pulp is non-vital, go for the endodontic first and then institute the periodontal therapy later. So first thing you have to check the vitality of the pulp. Okay, if the pulp is non-vital, you know, sure shot, it is endo. If it is vital, no need to go for unnecessary RCTs, okay? Go for the periodontal treatment. But if both the problems are occurring in the tooth, then it is always endodontic first and then the periodontal problem, provided the pulp is your non-vital. So condition of the pulp is very important. In conclusion, it should be understood that periodontal disease may be responsible for the entire loss of the supporting apparatus around the tooth and may in addition be the cause of the breakdown of the pulpal tissue. In such cases, endodontic treatment will not contribute to periodontal healing and the problem will have to be solved by periodontal approach.